Good morning, everybody, and welcome to today's Infectious Disease Echo. My name is Brian Hendricks. I'm the Quality Improvement Data Analyst at USET. We have some great presentations today. We have Dr. Brown doing the EPI updates for flu and respiratory infections, right? Okay. And he's also doing the COPD and asthma. And then Dr. Mara is going to do the microbial presentation, and Emily is going to give some quick housekeeping tips.
Good morning. Happy New Year, everybody. I am going to share a link in the chat quick. Please, at the end of this session, give us feedback. You can also claim continuing nursing and medical education units. We do this in collaboration with Cardia. If you have any questions about that, please contact one of the USET folks and we can pass along your question to Cardia. This is being recorded. The recording will be shared within the week, and you can also get continuing education units from watching the recording. I don't think we have any disclosures to disclose today. And please go ahead and introduce yourself in the chat. All right.
Thank you, Emily. And we can go ahead and get started with the presentations. Let me pull up Dr. Brown's somewhere. Here we go. Can you see the slide?
I can see it well.
Okay.
Thank you, Brian, and thanks for advancing the slides for me too. Good morning, everyone, and Happy New Year as well. I'm going to be pinch hitting today. How's my sound quality, Brian?
Sounds good.
Sounds good. Good. All right. So I'm going to be pinch hitting for my colleague, Anna Greer, who normally gives this report. But this is our monthly update on seasonal respiratory viruses. Really, it's influenza, RSV, and COVID. Next slide. So we have been monitoring these respiratory viruses for quite some time. And basically, I'm going to be going over the influenza-like illness report. Influenza-like illness is exactly what it sounds like. It's anything that presents with symptoms that are like influenza, but it's not laboratory diagnosed influenza. So I'll talk about ILI first, and then the laboratory diagnosed influenza, RSV, and finish up with COVID next. We are doing weekly reports that some of you should be getting. At least your health director should be getting these reports. And if you'd like to add your name to the list, we can do that. Just contact Anna Greer. We do an aggregate report on the USET region, and we send this out via the USET programmatic alert mail list. So if you want to get those, just let Anna know. Go ahead. So we base this off the MMWR, that's the CDC publication, and they number each week of the year. And right now, we have data up through the very end of the year. So that would be week 52, which ended right at the end of December. Next slide. So first, I'll talk about ILI next. So if the take-home message here is that the Indian Health Service has an ILI monitoring system, and this information is from that. So nationally, it's up slightly from the previous week. In our area, it's down slightly. However, the Nashville area is higher than the national average. And the percent of ILI visits by age is highest in the youngest and it's lowest in the oldest. So, and goes down proportionally, but that's not terribly unusual. Next slide. So the map on the top of the slide is, of course, the United States as a whole, and you can see that influenza-like illness right now is highest in the Southeast and New Mexico, but it's actually high over most of the country, with Oklahoma and Iowa kind of being the lowest there. But we're really seeing a lot of influenza activity. The bottom graph shows the last 6 years ILI activity, and we are that sort of green line this year. And as you can see, we're currently at about the peak of where 2019, the influenza season just before the COVID pandemic. We're just slightly lower than last year's peak, which actually occurred pretty early, unusually early. We normally don't see a peak of ILI until sometime around February. So we don't know where the curve's going to go, but I expect it may go up some more. Next slide. So we'll now get into specifics about the three common respiratory viral infections that we see in the winter. Next. So all three of these, actually RSV has been pretty flat. We are seeing a slow rise in both COVID and influenza. And that top line is the three combined. So as you can see, it's been kind of steadily rising for the last few weeks. Next slide. This is the USET area states. You can see that the percentage of respiratory visits is highest in the Carolinas, followed by Virginia, Louisiana, Mississippi. It's lowest right now in Maine and Rhode Island, but overall it's fairly high. Next slide. So let's get more specific about influenza. Next slide. This is influenza vaccination. So Nashville area has done pretty well. Navajo area has beaten everybody by a lot, but Nashville is actually second highest in the rate of influenza vaccination, just nosing out Albuquerque. This is good. I can remember when Nashville was consistently last, but over the years, all of you have done a lot of hard work to sort of institutionalize annual influenza vaccination. I think you have done a great job and you're to be commended for that. If you look at it by age group, it's the very young and then the older who seem to have the best uptake nationally in the Indian Health Service. With overall nationally, the elders are just right at about half of them have been vaccinated for influenza. So that's good. Next slide. So this slide shows that predominantly in terms of just lab diagnosis, we're seeing a lot more influenza A than influenza B. I kind of have to look carefully at the colors there. Hospital admissions are going up, but they're not, dramatically up from what they were before. And if you look at the IHS Nashville area, our vaccination rate for children is 22%, which is better than the national average. And our rate for seniors is 54.5, which is better than the IHS national average. So we're doing good there. Next slide. So let's shift gears and talk about COVID-19. So what we are seeing, basically, this is the case positivity rate, and it's not been really spiking, but has on the average been going up. The top line there, the sort of gold and yellow is the United States overall. And then the other line, the sort of maroon line, is for the USET region states. And we're a little bit under the national average. Right now, the leading variant is JN1. It's kind of quickly taken over as the leading variant worldwide. And the United States is no exception to that. Fortunately, JN1 is just another son of Omicron, doesn't appear to be any more virulent. So we'll keep our fingers crossed that that continues to be the case. Next slide, please. So the weekly hospitalization rate has stayed fairly constant, although it has risen slightly. Right now, we're only seeing about 1 per 10,000 people being hospitalized for COVID. Next, please. You can get tribal nation-specific reports customized for you. If you want to do that, you need to contact Anna Garrett. Next slide. So that's Anna's email address there. She's the one who's in charge. She's assisted by Greer Harper. Both of them are out this week on training, which is why you're having to put up with me. But Greer and Anna should be back in the office next week. So if you would like to contact anybody about these reports, those are the addresses to use. All right. And so for today's didactic presentation.
Real quick before we have, Gabby has a couple announcements, and I need to switch slides.
Okay, so thank you for the intermission. Thank you, Dr. Brown, for taking over for Anna and Greer. I greatly appreciate those insights. So I just wanted to hop on in case you don't know who I am. Of course, I am the Infectious Disease Program Manager here at USET, but I wanted to give you some information as we have the new year in. We are actually wanting to change the scope of our current infectious disease echo so that it'll be more culturally centered, engaging with indigenous determinants of health and traditional medicines that pair well with the Western medicine. So I will provide in the chat the brief survey. It is a 5-question survey, and it is completely anonymous, and we encourage anyone to take the survey so that we may get better insight as a broader scope. The other thing that I wanted to bring attention to is our HIV, HCV, and substance abuse disorders clinical training that we have going on coming in May. So that will be held in Miami, Florida. And we will also be providing travel stipends, for those who request. The training will provide attendees with the ability to recognize the importance of universal screening and universal treatment of hepatitis C and HIV, as well as examine epidemiology and prevalence and gain insight from subject matter experts who will be able to give recommendations as far as assisted treatments during indications and side effects of specific diseases. And they will be held May 21st to the 23rd, and it'll be from 9 a.m. to 4 p.m. each day. And again, travel stipends are available, and we ask that if you want to book your room, there'll be a link I will be providing in the chat, and if you can just book it by the morning of April 20th to receive the discounted rate.
And continuing education credits are available
yes.
for that as well.
Thank you.
Yep.
Can you send that information through an email? Would that be okay?
Yes.
Yes.
That should be a great conference. Okay, so today's didactic presentation is on chronic respiratory illness. And when we say chronic respiratory illness, we're really talking about COPD and asthma. I'm going to just give a background, and then Dr. Mira is really going to go take a deeper dive into the treatment of exacerbations, when to use antibiotics and when not. So if you could go ahead and go to the first slide. I guess that's the title slide I see there.
Are you still seeing the title slide or are you seeing the next one?
I just see the title slide, and it's not in slideshow either. But
Hold on. Sorry about that.
no problem.
Thought I was sharing the screen too.
There we
Is that
go.
fine?
Yeah.
Okay.
Okay. So yeah, I'm going to talk about COPD and asthma, just give you some background, talk about some definitions and the pathophysiology of these conditions. I'll talk a little bit about the epidemiology because that's what I do. And I'm going to just briefly go over medications. This is not an in-depth talk about COPD and asthma and their treatment. Those would be whole separate talks, or maybe even a series of separate talks. I don't have any conflicts of interest to disclose. Next slide. So what is COPD and asthma? Well, both of these conditions have a commonality in that they cause obstruction of airflow in the airways of the lungs. So chronic obstructive pulmonary disease, which is quite a mouthful, which is why we usually say COPD, it's a disease of adults. It's characterized by a chronic breathlessness, chronic cough, and an irreversible airway obstruction. Asthma is different in that it can occur at any age. It's characterized by intermittent symptoms of breathlessness, cough, wheezing, and reversible airway obstruction. So really the big difference, they both can have fairly similar presentations in terms of symptoms and signs, but the real difference is COPD has irreversible airway obstruction, whereas asthma, the obstruction is reversible. Now, one thing to keep in mind is there is no law that people have to have one or the other. People, in fact, quite a few people have both. A lot of people with asthma will eventually develop COPD, but then there can be some overlap. So sometimes it's confusing to diagnose. And you might even need to get, a pulmonologist to weigh in on it. But a lot of the management is similar. So that's sort of to the good. Next slide. Just wanted to review quickly kind of the anatomy of the respiratory system. So when we talk about the respiratory system, we're talking about everything from the nose all the way down to the little alveoli in the lungs. But if you look at that middle picture, you see the trachea or the windpipe, which divides into the two bronchi, the right and left mainstem bronchi. And then it branches out like a tree, so the bronchioles are they can be fairly large, but they can also get very tiny. And when we talk about airway obstruction, it's usually occurring at the level of the bronchioles. So smaller than the trachea or the bronchi. And then we go all the way down to the alveoli, which are the little air sacs in the lungs. And these little sacs are surrounded by capillaries that carry deoxygenated blood. And then the blood gets oxygenated by gas exchange at the level of the alveoli there. And then that oxygenated blood gets pumped around to our body. So the lungs basically remove carbon dioxide and add oxygen, and that keeps us all alive. Next slide, please. So we'll talk first about COPD. It's pretty uncommon prior to age 40. I mean, people can develop it younger than that, but it's not that common. There are really two underlying disease states that comprise COPD. One is chronic bronchitis. That's really a clinical diagnosis, and it has a definition that's pretty well defined and has been for years and years. But it's chronic bronchitis is having cough and sputum production for at least 3 months out of the year for 2 consecutive years. It causes airway obstruction due to inflammation, the mucus that gets, plugs up the airways, and bronchospasm. So that's how chronic bronchitis causes chronic airway obstruction. Emphysema is a little different. It's actually loss of lung tissue, especially the elastic tissue in the lungs. And emphysema causes obstruction due to a lack of that elastic support tissue around the airways. And so the airways tend to collapse because they've lost their support tissue. So these two conditions are different, but they often coexist. So most people with COPD have some degree of each of these. Occasionally, you'll find somebody who's more purely chronic bronchitis or more purely emphysema, but most people, there's some overlap. They have both. COPD has exacerbations that are usually triggered by some sort of infection, some sort of respiratory infection. And that's what Dr. Mira is going to talk to us more about in just a minute. Next slide. So COPD tends to be progressive over time. People get increasingly breathless. They have fatigue and exercise intolerance. And this is caused by, a gradual decrease in their lung function. Sometimes chronic hypoxia will lead to pulmonary vasoconstriction, which then leads to pulmonary hypertension, which will then cause right heart failure. So cor pulmonale or right heart failure is a common complication of COPD. The major cause is smoking. The majority of people with COPD, it's caused by smoking, and it usually takes somewhere around 20 pack years or so, with a pack year being defined as 1 pack per day for a year. You can actually show people that have 5 pack years of smoking, you can show some changes on spirometry at that level of smoking, but by 20 years is when people tend to develop COPD. Not everybody that smokes will get COPD, but a lot of people will. But there are other causes. A significant minority are caused by exposures to other particulate matter or fumes, such as from air pollution, wood smoke, or a lot of different occupations like coal mining or woodworking. Wood dust can commonly cause this too. Alpha-1 antitrypsin deficiency, which is a hereditary, fortunately not that common, but that's another important cause. The diagnosis is made by, so you have somebody with the clinical picture, they have the symptoms, and then you do spirometry, and there's a definition, and that is the forced expiratory volume over 1 second divided by the forced vital capacity. If that ratio is less than 0.7, that gives you the diagnosis. So fortunately, when you send somebody off for spirometry, generally you get a report back that tells you exactly what it all means. So next slide. Let's shift gears and talk about asthma. As I said, asthma can affect any age, although prior to 1 year of age, you probably shouldn't label somebody as asthma, even though they may have the classic symptoms. The onset is often in childhood, becomes kind of rare after age 50, although people can have it that late in life to have the onset. Now, if people have asthma in childhood, a lot of them will sort of grow out of it around puberty, but a lot don't. And even those that do stop having asthma in puberty. Sometimes later in their adulthood, the asthma will come back. So it's got a variable sort of course. The underlying disorder in asthma is the smooth muscle around the airways are hyperreactive. So they get some kind of stimulus, and that can be a lot of different things, but it causes that smooth muscle to constrict, narrow the airways, and you get wheezing, expiratory wheezing, shortness of breath, and a cough. There's a huge spectrum of severity. Some people may just get, an attack every now and then. It's not too severe. Other people have it every day and have to take, several medications to keep it at bay. The real hallmark is that the airway obstruction is reversible. And you can show that if you send somebody for spirometry and they do spirometry, then give them a bronchodilator, something like albuterol, and wait a few minutes and do the spirometry again, you can show that that airway obstruction is reversible. There are a number of things that can be released from mast cells, such as histamine, prostaglandins, and leukotrienes, that cause the airway to be hyperreactive and causes the bronchoconstriction. And a lot of the medications that we use are aimed at these substances. Next slide. So, there are a lot of different things that can cause an asthma attack. Dust, pollution, allergy is a very common cause. So people who are allergic to various pollens and dust and things like that, dust mites, that can trigger asthma. There's a category of asthma known as exercise-induced asthma. These people, just when they do heavy exercise, it brings on an asthma attack. Cold air for some people can be a stimulus. Emotional stress is a pretty common asthma stimulus. There's a subset of people that are very sensitive to aspirin and nonsteroidals that get an asthma attack triggered by that. Aspergillosis is a not terribly common cause, but it is out there. But various infections of the upper and lower respiratory tract, common initiator of an asthma exacerbation. And again, Dr. Mira is going to talk to us more about that. Next slide, please. So the epidemiology, COPD affects about 10% of people who are older than 40 or 40 and older. And the prevalence of it increases with the age. It is a very common cause of death. Prior to COVID, COPD was the third leading cause of death worldwide. And we have about 120,000 people a year in our country who die from COPD. Asthma is kind of interesting because, while lots and lots of diseases are more common in resource poor countries, asthma is one of those diseases that you see more in resource rich countries. I'm not sure why that is, but it affects about 5.5 million children under the age of 12 in the US, so a very common pediatric disease, probably the most common chronic pediatric disease. Prevalence in the US, about 8.4% of children, and these statistics are a few years old, this is about 5 years ago. It had a prevalence of about 8.4% in children under 18, about 7.7% of adults. So you can see that, it's a pretty common disease. Next slide. So I'm just going to very briefly touch on treatment. For COPD, smoking cessation or avoidance of the environmental factors is most important to prevent COPD. And if you have COPD, stopping smoking at any stage will help. For asthma, it's very important to avoid the things that trigger it. And also, if somebody has allergies, allergy treatment can often be of benefit. But there are two medicines that are really the mainstay of treatment for both these conditions, the so-called beta agonists and then steroids, glucocorticoids. The anti-muscarinic agents are also useful, especially in COPD. But for exacerbations of both of these conditions, steroids are often very important in the treatment. And maybe antibiotics. And again, Dr. Mira is going to talk to us about that. That's much more common with COPD. Next slide. So I'm just going to go over these medications. You often see these abbreviations. So SABA are short-acting beta agonists, and these are the so-called rescue medicines. Albuterol and levoalbuterol are the common ones. These older ones aren't used much anymore, like metoprolol and terbutaline and epinephrine. LABAs are long-acting beta agonists, and these are important in sort of chronic treatment. Formoterol is sort of an interesting one because even though it's long-acting, its onset is very fast. These others, the onset is slower, but formoterol sort of has a special status. SAMAs are short-acting muscarinic agents. Ipratropium is the one that's commonly used. LAMAs are long-acting muscarinic antagonists. So tiotropium and umeclidinium, I have a hard time with that one. These are the long-acting anti-muscarinic agents or muscarinic antagonists. And then there are inhaled glucocorticoids like mometasone, beclomethasone, fluticasone. And then we often use systemic steroids in treatment, both oral and parenteral, usually IV. And I think that's about the end of my talk. Yeah. So I can stop now for questions, or you can save them for the end. If you ever want to contact me, that's my email address and my phone number. And I'd be happy to take questions anytime.
Thank you, Dr. Brown. Do we have any questions for Dr. Brown at this time?
So I have one, a quick one. From your epi data, and thank you for your presentation. It was really good. And your epi also. So is there, maybe I missed it, but you showed a slide on hospitalizations due to COVID. But I don't know, did you show, have they increased? That's my question in the last month. Maybe I missed that slide.
I don't think the slide was very specific on that. COVID hospitalizations have been up very slightly, but it varies around the country as far as the hospitalization rate. Fortunately, we're not seeing a huge increase in hospitalizations at this time.
Okay, and to piggyback that question, on the reports that you get, do they mention if the hospitalized patients are vaccinated or not, or that's not included in the report?
No, I don't get that information. It'd be nice to know.
Yeah, my suspicion is that they probably have lower rates, but I don't know. I mean, that's just a gut feeling.
Sure, and I'd be willing to put at least a $20 bill on your gut, because that's mine too. And I'm not a betting man, but
Okay, great. Thank you, Dr. Brown.
sure.
Hearing no further questions, Dr. Merritt, would you like to proceed? You're on mute, Dr. Merritt. Dr. Mary, you're on mute. Oh, there you go.
When I put the slide mode, I can't find the mute button, so I had to go back.
Gotcha.
Thank you. Okay, as Dr. Brown, well, thank you for doing that introduction on COPD and asthma, but it just makes my life easier on this presentation. So I'm going to be talking about the antimicrobial use in patients with COPD and asthma, and I'll start with COPD, which is the more complex one. I just wanted to mention, I'm not going to be talking about specific antibiotics. I'm going to talk more about the indication of the antibiotics, but happy to answer questions on that part. So first, it's important for clinicians to, okay, and one thing I want to mention is it's critical to use them correctly, because this is an area of a lot of misuse of antibiotics. So the first thing is that we need to have a definition of what is a COPD exacerbation, and by consensus, it's defined as an event that's characterized by dyspnea and or cough and sputum that worsens in the last 14 days. And why did they put this time frame? Is because a lot of people with COPD may have chronic dyspnea or chronic cough or chronic sputum production. So you need to make sure that something new is happening to that patient in the last 2 weeks. And of course, it could be complicated by other symptoms, but there's like tachypnea or tachycardia or signs. But it is the presence of a new onset or increased dyspnea. Someone who has chronic dyspnea, they'd have to be more short of breath than they were before, and the cough and the sputum production. So that's important to have in mind. And it also is important that 80% of COPD exacerbations are caused by respiratory tract infections. The rest, there's room for pollution or other exposures of non-infectious agents that can trigger it, or sometimes people forget to take their medications, and that triggers an exacerbation. Now, when someone, although the majority are infections, we will see in the next slides that the majority of these are viral infections. So unless that viral infection has an antiviral treatment available, the patients may need that, but they do not need antibiotics. So usually the indication to use antibiotics are for those patients that you think that the exacerbation is being caused by a bacterial infection, that you may use empirical antibiotics, or those who are so ill that will require hospitalization and or with or without ventilatory support. You will probably need to put those patients on empiric antibiotics until you can figure out what caused the exacerbation. So in summary, anybody who gets hospitalized should be treated with antibiotics when they get hospitalized for a COPD exacerbation, or if there are some signs or information that tells you this could be bacterial. So the best way to decide, and this is a good thing, to decide if you need to place the patient on antibiotics is based on symptoms. So it's not any particular test that you will do, but basically symptoms. So that's easy information to have. The three cardinal symptoms that you have to look for is the patient, does the patient have increased dyspnea or shortness of breath? Does the patient have increased sputum production, and or is the sputum more thick than before? And the third one is does the sputum look purulent? So those are the three cardinal symptoms. Anybody who has two or more of these symptoms should be placed on antibiotics. And on the bullet below, what is the risk of actually I should say bacterial infection if someone has any of these symptoms? If they only have one symptom, 6% chances that they have an infection. If they have two symptoms, it's 35% chance. And if all three cardinal symptoms are present, 80% chance that they have an infection, a bacterial infection. So anybody who presents with two cardinal symptoms, you would be authorized morally and scientifically to prescribe antibiotics. But anybody who gets hospitalized or needs ventilatory support, that usually it's done in the hospital. But I think they put this on the definition in case you're in the emergency room and you haven't been hospitalized yet. So all these would require antibiotic prescriptions. So just to make it more clear, when is an antibiotic not recommended? If you only have one cardinal symptom, and if you're not hospitalized or do not require antibiotic ventilatory support. The most common bacterial infections are listed here. It's Haemophilus influenza, Moraxella catarrhalis, strep pneumo, and Pseudomonas aeruginosa. Of the viruses, the one who leads the pack is rhinoviruses. And then you have coronaviruses, which include COVID-19, influenza, parainfluenza, adenovirus, and respiratory virus, RSV, respiratory syncytial virus. And that order is the order I place them is the magnitude in which they occur. Now, it's important to understand that many patients, up to 13% or 14%, may have co-infections. They may have a viral infection, and they may also have a bacterial infection. So as I mentioned, 70 to 80% of the exacerbations of COPD are due to a respiratory infection, but the majority are viral. Viruses can be detected from 1/3 to 2/3 of patients with COPD exacerbations. And that really depends on what technology you're using to detect the viruses. The more sophisticated technology, meaning you have a multiplex PCR platform like a film array or similar, you can detect many viral infections. Now, it is also very critical to understand that 15% of asymptomatic individuals who have stable COPD, if you swab their noses and do a respiratory panel, you will find a virus. And that means that it's probably being colonized by the virus, but it's not causing disease. With bacteria, similar things happen. 1/3 of the exacerbations are due to bacteria, but many individuals are colonized already, chronically colonized with bacteria. So the mere isolation of a bacteria in a sputum culture does not mean that that bacteria is causing an exacerbation. And interestingly, I think I have another slide for this, but I'll mention it here in case I don't. It has been proven in several studies that exacerbations are caused by new bacterial infections. So a patient may have a Pseudomonas chronically, that probably is not going to cause a problem. But if he acquires a Pseudomonas, a different serotype of Pseudomonas, or different serotype of pneumococcus, or Haemophilus, etc., those are the ones that trigger the exacerbation. So that's why it's really, except for in some situations that I will clarify, you do not need to get sputum cultures to decide if you're going to give the patient antibiotics. You might need to get them if you want to titrate your antibiotics to the adequate one, but not to decide if the patient gets or doesn't get antibiotics. So here we go. When to obtain sputum cultures? One, when the patient has a risk factor for being colonized with Pseudomonas, and I'll show you what those risk factors are. Patients, anyone who requires hospitalization, you're going to be placing these patients on antibiotics no matter what. But then you want to know if you need to change your antibiotic based on the culture results. Or anybody who's failing to improve on an initial empiric antibiotic therapy. For example, you see a patient as an outpatient. They have 2 cardinal symptoms, but they are not required to be hospitalized. You put them on antibiotics and they don't improve, then you would need a sputum culture. What I do, and this is a little bit off the guidelines, is that since sputum cultures, you don't get results immediately. You get results, in 48 hours, best case scenario, or 72. I sometimes will get a sputum culture in case I need those results to modify my treatment, and I have that when the patient's failing 2 or 3 days later. But it is important to understand that cultures do not differentiate colonization from infection. So just the fact that you find a bug in a culture, a sputum culture, does not mean that that bug is causing anything. Other diagnostic tests, unfortunately, procalcitonin and C-reactive protein have not, the studies have not demonstrated a great added value to clinical judgment alone on initiating antibiotics. So to initiate, that's probably all you need. Now, if you do get a procalcitonin, it may be good for the duration of treatment. This has been well proven for pneumonia, not so much for COPD. But let's say you're going to treat a patient with COPD for 5 days, and on day 5, you want to know if you're ready to stop. Procal that is normal, below 0.25, could guide you to saying, yeah, the patient's ready to stop the antibiotics. And if it's high, you may want to push it for a few more days. When to test for respiratory viruses? I would say always, because COVID-19 is not strictly seasonal. It increases in the winter periods, but you can have it all year round. And you can also have influenza and RSV and not epidemic season. But usually, I would say if you want to save money, do COVID all the time, but do influenza and RSV during the epidemic season. When to obtain chest imaging? Anybody who's hospitalized will need some either a chest X-ray or a CT, and the data is not very clear on when to recommend it for outpatients. What I would say is this: you need to treat bacterial pneumonias all the time with antibiotics. So if the X-ray will change your management, obtain one. If it's not going to change your management, it's just wasting money and irradiating the patient. Let's say you decide to place the patient on antibiotics. Well, probably it's going to be the same antibiotics that you will treat a pneumonia for. So in that case, you may not need to get an X-ray. So how to stratify patients to guide antibiotic selection. So outpatient versus inpatient. So inpatient or patients who are being hospitalized will always require antimicrobial therapy. The ones that are outpatients will depend on cardinal symptoms. But if the patient has risk for poor clinical outcomes, let's say he has a comorbidity like CHF or coronary artery disease or chronic kidney disease, etc., or they have very severe COPD defined as an FEV1 less than 50%, or their baseline, or they are already on supplemental oxygen for their COPD, or they're older, then these patients may warrant antibiotic therapy because of the poor clinical outcomes they may have if you don't treat them. Risk for Pseudomonas infections, this applies to anybody who's hospitalized, anybody who has chronic steroid use, or they have been on broad spectrum antibiotics in the last 3 months, or they have bronchiectasis on chest imaging, or have a very poor FEV1 of less than 30%, all those are at risk of a Pseudomonas infection. So if you decide that you're going to treat the patient with antibiotics and they have any of these risk factors, the antibiotic should cover for Pseudomonas. And that's the meaning of this definition. If they do not have these risk factors, you do not need to empirically cover for Pseudomonas on your antibiotic regimen. Why is this important? Because if the patient's an outpatient, there's only one class of antibiotics that cover Pseudomonas, which are quinolones. So you need to use them if the patient meets these criteria, but you do not need to use them if they don't meet these criteria. As I mentioned, I'm not going to talk about the specific antibiotics to administer because they depend on many variables and it'll be different on many sites. So it depends on what is the most likely pathogen in your area, patient's risk status, prior antibiotic exposure. For example, if someone has been getting amoxicillin clavulanic acid in the last month for sinusitis, that's not an antibiotic I would choose to start the patient on. But if the patient's free of antibiotics, that would be a great option to treat a patient. Prior clinical response to specific antibiotics, history of allergies. If they're allergic to penicillin, then you probably won't be able to use beta-lactams in general. Intolerance to antibiotics, drug-drug interactions. For example, if a patient is on amiodarone for AFib, you cannot use quinolones. So that's just an example, but there are many of them. And again, if you have susceptibility patterns of that organism, that may change your decision on which antibiotic to use. The duration of antibiotics for outpatients is about 5 days. And for patients who are hospitalized, it's 5 to 7 days. And that's where I use the procalcitonin when they're hospitalized. If at 5 days the procal is normal and they are clinically improving, I may just cut it at 5 and not prolong therapy. So other interventions, antiviral treatment, and this is something that I've observed that we are generally deficient on. I see a lot of people getting influenza that are not being treated for it, or even having COVID-19 and meet criteria for treatment and they're not receiving antiviral treatment. So have in mind that COPD is a risk factor for complications. So anybody who has COVID-19 and COPD should be offered antiviral treatment. Same as for influenza, everybody with influenza that's being hospitalized or that has a COPD exacerbation should be offered antiviral treatment, which there's several of them. Oseltamivir is the one more commonly used, but baloxavir is also another option. Of course, vaccinate your patients. I forgot to put one vaccine here, which is a Tdap. Make sure they have, Tdap, pneumococcus, influenza, and SARS-CoV-2 up to date. And in a very small subset of patients, those that are having recurrent bacterial COPD exacerbations, you may consider putting them on prophylaxis with azithromycin, at least during the winter months. But we do not do this on every single patient. Okay, this is just briefly showing you where the data comes from this. All these recommendations are not just based on expert recommendation, they're based on clinical trials. So the European Society for Respiratory Diseases looked at 5 trials that evaluated antibiotics in ambulatory patients with COPD. 2 of these trials that they chose to analyze because of the quality of the trials had over 400 people enrolled. And 3 of the trials were excluded because either the COPD diagnosis was not done adequately, or there was not good treatment failure data, or because there was not enough data, period, on the other study. And they look at all these criteria to base their recommendations. So treatment failure, which was a composite of death or not getting better or getting worse, adverse events, how many, when was the next COPD exacerbation if they got treated with antibiotics on this one, if they were hospitalized or not, length of stay, and death. And what they found was that on the antibiotic therapy, that the patients who were randomized to receive an antibiotic treatment decreased the treatment failure rates. The ones who got antibiotic was 27% failure rates, whereas for the ones who did not get an antibiotic, was 42% failure rates. And remember, failure is defined by death, or the patient's getting worse, or the patient's not getting better. Also, there was a difference in the time to the next COPD exacerbation on the ones who got antibiotics, or it was lower, 73 days less, medium. And there was a trend towards more adverse events on patients who received antibiotic therapy, which is not surprising because they're getting an antimicrobial that can cause problems, and was about a little bit less than double compared to placebo group. And they did not get the information on hospitalization, death, and lengths of hospital stay were not reported. So this society recommends that the use of antibiotics in ambulatory patients with exacerbation of COPD reduces treatment failure rates and increases the time to the next COPD exacerbation. But it is interesting to note that most patients that were in the placebo group did not fail treatment, like 58% did not fail treatment. Still, there's a 42% that failed treatment, and on the group that got antibiotics, they did better. So the summary overall for COPD exacerbations, that antibiotics are beneficial, particularly in patients with purulent sputum and severe exacerbations, and that the selection of antibiotic depends on the safety profile of the drugs and what local flora you have on your area. Duration of treatment range from 5 to 14 days, but it's usually 5 to 7 days. And patients with severe airflow, with severe obstruction, or if they're hypoxemic or hypercapnic, should be admitted to the hospital. Asthma is don't worry, I don't have the same amount of slides for asthma. I think I have 1 or 2 slides, because guidelines do not recommend the use of empiric antimicrobials. Most exacerbations are triggered by viruses, and this is evidence-based recommendation. And only give antibiotics on an asthma exacerbation if you suspect that they have concurrent bacterial pneumonia or bacterial sinusitis. And I'll stop there. I'm happy to take any questions if there are any.
Thank you, Dr. Mara, for a really great presentation. Do we have any questions at this time for Dr. Mara? Okay. No questions at this time. So please don't forget to fill out the survey. The link is in the chat box right now. It'll also pop up when you close out the Zoom window. Um, so that is it for us. Thank you all so much for joining today, and we'll send out the recording link and information following the presentation. Thank you.